Good afternoon, everyone, and welcome to our webinar, Brain Health and Aging. My name is Tony Brantley, and I'm a program coordinator with the Community Health and Wellness team at Suburban Hospital located in Bethesda, Maryland. We are thrilled to have you with us today for this important discussion. Throughout the presentation, we encourage you to submit any questions for our guest speaker using the Q&A box at the bottom of your screen. At the conclusion of the webinar, a short evaluation will appear. We will greatly appreciate your honest feedback as it helps us improve future programming. Please note that today's webinar is being recorded, and a link to the recording will be shared in the coming days. Again, thank you all for being here. It is now my pleasure and honor to introduce our distinguished guest speaker, Dr. Ji Bang. Dr. Ji Bang is an associate professor of neurology and psychiatry at Johns Hopkins. She completed her residency training at the Johns Hopkins Hospital, followed by fellowship training in behavioral neurology at the University of California, San Francisco. She specializes in caring for patients with disorders of cognition and movement, including Alzheimer's disease, Huntington disease, progressive supranuclear palsy, corticobasal degeneration, multiple system atrophy, dementia with Lewy bodies, and frontotemporal dementia. Without further ado, I present Dr. Ji Bang.
Thank you so much for that introduction. Good afternoon, everyone. So today in this webinar, I am going to be discussing brain health and aging and some ways we can manage the best we can through this process. And so let's get started here with, there we go. So the topics we're going to be discussing is what brain health is, and I will also talk about the differences between normal aging and abnormal aging, and what the terms MCI or mild cognitive impairment versus dementia mean, and the different types of dementia. I will just be kind of listing those, but will not be discussing all of those in detail due to time constraints. And I will also be talking about some modifiable factors to take the best care of our brains we can. So what is brain health? So in general, most famously, we think of cognitive health, our brain's ability to help us think, learn, and remember things. But as brain is the boss of the body, it is in charge of helping us do a lot of other things. So brain health also has to do with controlling our motor function, so controlling movements and balance. And the brain also helps us with our sensory functioning, so it helps us see, hear, taste, and smell, as well as tactile function. So that has to do with feeling and responding to touch, such as pressure, pain, and temperature. And also importantly, brain health has to do with the processing of emotional function, so interpreting and responding to emotions. Of all these functions, we will be focusing on cognitive health today, but I wanted to acknowledge that the brain health really refers to a lot of other functioning in our bodies as well. And our brain health can be affected by a lot of different things. So one is natural age-related changes in the brain. The brain health can also be affected by injuries such as stroke or traumatic brain injury. It can also be affected by mood disorders, whether that's depression or substance use or addiction. And it can also be affected by diseases such as Alzheimer's and other related dementias. So what's normal aging? So it is known that thinking abilities peak around age 30. And since, after that point, there's very subtle decline with aging over time. And that can include overall slowness in thinking, difficulties with sustaining attention, multitasking, and holding information in mind and word finding. But just because, we peak around age 30, I would not panic because there are some things that with normal aging that are either unchanged or even improve. And those things include vocabulary, reading, and verbal reasoning, which is the mental process of using language to think logically, solve problems, and make decisions. So it's not all downhill from age 30. But what is abnormal aging? So we start to think about that when the natural declines that I had just talked about in cognition are more severe. And it may also include other thinking abilities or affect other thinking abilities, such as someone with rapid forgetting. So they just had the conversation with you. It might have been a couple days ago or even a few weeks ago, and they seem to not have the recollection of that conversation. And sometimes, if you remind them, they may kind of recognize that it was talked about, so it might ring a bell. Other times, it might not ring a bell, and either case can be alarming to some people. But yeah, if there's a sense of rapid forgetting, that may be a sign of abnormal aging. Or sometimes the person may have difficulties navigating. So even in familiar routes that they've always walked around or driven around, suddenly they're getting really confused or turned around or solving common problems or expressing oneself in conversation. They might have difficulty coming up with words, or they're kind of talking around what they want to say. Sometimes that could be an indication of abnormal aging as well. And another example is someone behaving outside of social roles. So they are being socially inappropriate, what's considered a social norm. They're not really having a regard for that anymore. And sometimes that can be seen, as early as in their 50s. And if that's really inconsistent with who they are at baseline, their normal personality, sometimes that could also make someone think of an abnormal aging. Abnormal aging, besides cognitive changes, may also include motor changes, and sometimes those can include tremors or tripping or falling a little more often than one might expect, or in circumstances that seem kind of, there's no sort of obvious reason for why they're tripping or falling, or they're much clumsier than they used to be. So those might be also an indication for an abnormal type of aging. But what's normal for one person may not be normal for another person. And so it's not always easy to determine, is that part of normal aging or is that part of abnormal aging? So that's, I think, when some people decide to be evaluated by a cognitive specialist, for example. So part of abnormal aging are two terms that are often talked about. So MCI, which stands for mild cognitive impairment, and dementia. I think these two terms are often conflated or confused. So I want to kind of talk about those in more detail. So MCI, mild cognitive impairment, means that there is a decline in cognition that's greater than would be expected for that person's age, their level of education, or their development. And that is recognized by either the person or the people around that person. And if they're objectively evaluated by a clinician, There's also some change in cognitive testing, for example. But those cognitive declines do not affect that person's ability to carry out their usual daily routine, stuff like shopping or cooking or driving. So there is some change compared to how their cognition used to be all along, but those changes are not enough to impair their ability to independently carry out their daily functioning. So that's what mild cognitive impairment refers to. Whereas dementia is actually a very broad term. So the main difference between MCI and dementia is that, yes, there are all these cognitive changes, that there's a decline overall, and they do have an impact on the person's ability to carry out their daily routines independently. So that's the distinction, their ability to independently carry out their daily activities. If they still can, that would be MCI. If they cannot do those, that would be under the category of dementia. But just calling someone as having MCI or dementia, that doesn't really tell you what the causes are. It's kind of the state of being. It's just explaining what they're experiencing, but it's not telling us why they're experiencing those things. So an analogy I like to use is coughing. So, you could have MCI, you could have dementia, you could have coughing. If you say someone is coughing, that's telling you, they're having difficulty breathing and doing the act of coughing. But the causes could be a lot of different things. So someone could be coughing because they have a cold, or because they have the flu, or they have asthma, or there's reflux, there are allergies, and many other causes. But just saying they have coughing, we can't tell just by hearing that why and which of these causes are related to the coughing. So similarly with MCI, there are many different causes of MCI. So it is sometimes because they are experiencing Alzheimer's disease symptoms that are slowly coming on, or another dementia or neurodegenerative disease, because no one goes from being cognitively normal one day and then next day Alzheimer's dementia. There's a gradual process where their cognitive decline is progressive. So if you're kind of catching them in the middle of that process, you would call that MCI. And for some people, that's because it is a state of sort of a prodromal Alzheimer's disease. Or another cause of MCI could be because they have what's called vascular or small vessel disease in the brain. So there's a picture of some cases of cerebrovascular disease. So this is the brain, and we're looking at it kind of like if the person is lying down with their feet sticking out at us. And these are different sort of levels of the brain and different slices on the MRI. If you can appreciate these white spots and then white lines around these sort of black spaces, those are kind of like scarring or scar tissues, just kind of after the blood vessels have had some damage over time, and often that could be due to long-term blood pressure, high blood pressure, for example. The small blood vessels in the brain also can get these little injuries, and so we're kind of seeing the after effect of that. Kind of like if you've gotten a cut and then you see the scar. So you see what has happened to that area of the body. So these types of diseases or these conditions can also cause someone to have mild cognitive impairment. Another cause can be depression or another mood disorder. And because of the condition, the mood disorder not being adequately treated, that can sometimes cause people to have some cognitive impairment. Or they're on medications or substances that are linked or known to cause cognitive impairment. Or someone can have MCI because of either metabolic or endocrine deficiencies. Some common ones that we check for are if their thyroid levels are off, or if their vitamin B12 level is very low, or their folate level is very low. Those can certainly cause cognitive impairment in some people. Or there could be a sleep disorder such as sleep apnea. Sleep is extremely important, and that's clearly a whole topic in and of itself. But sometimes if people are not getting good quality sleep because they have sleep apnea, for example, that can also cause MCI. Now, these things in green, these are potentially reversible. If, for example, we see that the vitamin B12 level was very low, that's something that could be repleted. If somebody has sleep apnea, that they can start the treatment for that, like using a CPAP, for example, or if there are medications or substances that were causing the problems, they could be removed if possible. And depression or other mood disorders have a lot of effective treatments available. So that's good news that these things, some of these causes are reversible or can be reversible. So I want to just show graphically, again, kind of to summarize what we've been talking about, the differences between aging or normal aging and mild cognitive impairment and dementia. So in aging, normal aging, there are mild, very subtle cognitive changes. And in MCI, those mild cognitive changes are not only experienced by the person or or those around the person, but also objectively can be identified by a clinician who's assessing them. And in dementia, those cognitive changes are significant. And so in normal aging and MCI, the ability to carry out daily activities remains intact. Whereas in dementia, that ability is impaired. So someone could progress, if you look at the arrow down here, someone could progress from aging to MCI. And if the cause is due to an underlying neurodegenerative disease, such as Alzheimer's, then they could progress then from MCI to dementia. But this last arrow going the other way here, it's possible with those reversible causes we talked about that someone could actually go back from the MCI stage to normal aging process if those reversible causes are addressed, and those were the only reasons for the MCI. So let's talk a little bit about dementias. So there are lots of different types of dementias. So again, if somebody says, oh, so-and-so has a dementia, it could be any of these things that could be causing the clinical picture of dementia. So these are some of the, just sort of the top 2, 4, 6, 8, or top 8 lists, or top, I guess there are several under this category. Some of the top causes of dementia is Alzheimer's, clearly being number one, that may be seen in the cognitive clinic. So I will not be going through each of these, but I will comment briefly on Alzheimer's disease. And the rest of these are, again, big topics of their own. Okay, so Alzheimer's disease is the most common form of dementia, and it makes up about 70% of all dementias. And it can be Alzheimer's alone that can be causing the dementia, but a lot of the times it can be a combination of Alzheimer's and, say, vascular disease, or Alzheimer's and Lewy body disease that are coexistent. Lewy body disease, will not be going into detail in this talk. But just to say that either it could be Alzheimer's alone or Alzheimer's plus some of these other conditions causing the dementia together. And Alzheimer's is only becoming, even more common because everyone's living to older ages, or many people are. And so as people get older, the prevalence of Alzheimer's also increases. So I'm going to briefly touch on dementia care because I wanted to make sure we cover a lot of topics. So I will not be going into great detail, but I'll go into some details with these topics. So when someone has dementia, there are many ways we can provide care in meaningful ways. So one is to treat the cognitive symptoms, and we can also treat the neuropsychiatric symptoms, and I'll talk more about what those are. And anytime the medication list can be reduced, that can also be helpful in case some of those medications that someone is on, if it's no longer necessary, or if the side effects or the cognitive side effects of that medication outweighs the benefit for which they're taking that medication, that could be helpful. So it's always a great idea whenever people are seeing their primary care doctor, for example, to review their medication list carefully and always be reviewing each medication and their necessity. And sometimes it's a combination of some of the medications that the person is on together that could be causing problems. And I'll talk a little more about some of these topics a little bit later on too. But managing other conditions that can further contribute to dementia, such as hypertension, diabetes, or other cardiovascular diseases, can be very helpful in providing care for the person with the dementia. And people with dementia are more susceptible to developing delirium. So for example, if they're undergoing a major surgery and they already have dementia, or perhaps they were on the verge of MCI transitioning to dementia, and now following the general anesthesia, they're very confused, they're combative coming out of anesthesia. That can happen because their brain is already susceptible, and then with general anesthesia, they could further have greater confusion. So if you know that the person has dementia or they've been having cognitive issues, at least some discussions can be had with the surgical team, for example, so that people can act quickly or even try to reduce the chances of delirium. And supporting patients with dementia with activities that can really help stimulate their brain and ensuring their safety so they're not injured or lost or have other cases or instances where they could be hurt. That's also important to keep in mind. And it's always essential to also provide support for the caregivers. So there are, a lot of support groups where skills can be learned or shared, and ensuring that the caregiver has adequate break time or respite is critical, because often caregivers really think about themselves last, if ever. And it's important to note that a well-rested caregiver is a better caregiver for their loved one. So those are some of the dementia care sort of bullet points I wanted to touch on. And this guide, Practical Dementia Care, by our own Dr. Rabins and Dr. Luketsozen, and the team can be a useful guide for families. So a little bit more on medications. This is not an Alzheimer's disease talk per se, but I, excuse me, do want to touch on these medications. So we do have treatments for the cognitive symptoms. And one class of those medications are acetylcholinesterase inhibitors. And some of the names for them are listed here. Donepezil, or also called Aricept, or rivastigmine, which also is called Exelon, and it comes in both an oral and patch form, and galantamine. And these are medications that have been around for a while, and they provide symptomatic relief, as in they don't affect the course of the disease itself in Alzheimer's. Sorry, I should say these are approved for Alzheimer's specifically. So they don't slow down the disease progression or change the overall course, but they do provide symptomatic relief, which means they're designed to give some boost, which is temporary for either memory, thinking, or daily activities. So again, symptomatic relief, kind of like cold medications for a cold. If you take a cough medicine, it doesn't help you have a shorter duration of the cold, but it may give you some relief temporarily. The other class of medications which are newer are the class is called monoclonal antibodies. And the two that are most commonly used right now are called lecanemab, also called Leqembi, or donanemab, called Kisunla, and they're given through IV or intravenous infusion, and they're given every 2 or 4 weeks. These are different from the upper category, the acetylcholinesterase inhibitors, because these target the Alzheimer's process differently. So they are designed to actually provide disease modification, meaning slow down the disease progression. And they do so by removing this protein called amyloid, which is part of the underlying pathology of Alzheimer's. That's all I will say at this time for sort of an overview. And I'd like to talk about another important dimension of dementia care is to treat neuropsychiatric symptoms. And by that, I mean things like apathy, where the person is really not motivated and uninterested in doing any activities, and they really don't have the motivation to initiate. Sometimes, even if somebody else suggests doing them, they usually are not interested and can't be sort of convinced to do those. So that's a very common neuropsychiatric symptom of dementias. And in this case, not just Alzheimer's, but in a lot of different types of dementias. Another common neuropsychiatric symptom is depression. And that could manifest as being persistently sad, but also in the form of loss of interest, loss of energy, fatigue. And so it's not always being sad and tearful, but it can come in other ways as well. As the disease progresses, there can be more of sort of in this bottom half of the graphic here, more of these psychosis type symptoms. So one example is delusions, where they are really convinced and believe in things that are not true. Or they could also have visual or auditory hallucinations. So seeing things that are not there, that other people in the same room don't see, or hearing things that other people in the same room can't hear. And they might not always share that with those around them, especially if they can't tell because they're so vivid, then they might not think to mention that to you. Because they'll just take that as a fact or reality. Or other times they might be a little afraid to mention that because, they might worry what other people would think of them, They might think I'm crazy. But these are all symptoms coming from the brain being affected by these dementia disorders and can be treated effectively. And then other neuropsychiatric symptoms of dementias can include agitation, and they could be aggressive, either verbally or physically. So first line first line of treatment is always to kind of really figure out what is bothering them or why they may be behaving the way they are. Sometimes, if they're having difficulty verbalizing what they need, it could be something as straightforward as they're really hungry, or it's too hot, or they're really tired, or maybe it's a specific trigger, some other trigger that can be identified. So kind of giving those ideas and giving the training and the tools to the caregiver can be very effective. Changing their environment if it is because of, their hunger, or if because, the TV in front of them is really bothersome, or you can change some things around. So it's really all about, focusing on that person's needs and what may be bothering them. And if those non-pharmacological ways are not effective, then second line would be using medications. And there are a lot of different medications that can be carefully but effectively be used to treat these symptoms. So okay, I'm kind of switching the gears a little bit and wanted to address what are some major risk factors for dementia. We did talk about aging earlier, so advancing age is a risk factor, and the prevalence of dementia really does dramatically increase with advancing age. So if you look at people who are 65 years old, around 5% could have dementia, but if you take 85-year-olds, the prevalence really jumps up to 30%. Another risk factor is genetics. And for example, this is in Alzheimer's. This is more rare to have these what we call dominant genetic mutations. So there's a mutation in the gene that's passed down through every generation, for example. This is more rare than non-genetic, what we call kind of spontaneous cases. But sometimes that is, if that gene mutation is present, that's a risk factor. And there also in each person a protein called ApoE4, or the gene called ApoE, which comes in different forms, and some of those forms are more likely to cause Alzheimer's and are associated with greater risk. And lifestyle factors, and that will be sort of the last part of this talk, which is potentially modifiable lifestyle factors that can mitigate the risk of dementia. And so that will hopefully help us and in a positive way. So what are some modifiable factors that we can utilize or be thinking about for robust cognitive health or brain health? So one is vascular risk factors. So it is well known and has been shown very clearly that some of these conditions do increase the risk of dementia. So type 2 diabetes, high blood pressure, high cholesterol, obesity, and smoking. Another modifiable factor is physical activity, and we'll go into a little more detail for these. So moderate intensity physical activity has been shown to be very helpful for brain health. And cognitive activity, such as reading, puzzles, or games, can also be helpful. And social engagement is an important factor in preserving cognitive health as well. So utilizing social networks that the person has and friends and family. So vascular risk factors. So again, there have been many studies that have shown a clear relationship between increased vascular risks and cognitive decline. There was a trial called Sprint Mind trial, which looked at blood pressure and benefits for cognition. So this study looked at adults 50 years and older with hypertension, and the volunteers or participants were randomized to two different levels of blood pressure control. The upper number of the blood pressure control, which is called systolic blood pressure. So one group was assigned to strive for standard blood pressure control, which means less than 140 of the systolic blood pressure, whereas the other group was assigned to intensive treatment, which is a more aggressive lowering of the blood pressure to less than 120. And the study found that the intensive treatment group had benefits for cognition when it came to MCI. Not for dementia, but within the MCI group, the more aggressive blood pressure control was found to be beneficial for cognition. Another study, this one's done by Dr. Gottesman, who has been at Hopkins for a long time and is now at NIH. Her study, which she led with many colleagues, showed that hypertension in midlife does lead to an increased risk for dementia. So in this big study, they looked at people in midlife, in this case, ranging from 44 to 66 years old, and saw that or observed that hypertension is associated with a 39% risk in dementia risk over 25 years. And that's over 140 over 90. And in the same study, Dr. Gottesman and her colleagues also observed that midlife diabetes is associated with a 77% risk in dementia risk over 25 years. So very clear evidence that these cardiovascular or the vascular risk factors can have a big impact on cognitive health. Okay, physical activity. So physical activity is beneficial for actually many aspects of health. So it's helpful for reducing blood pressure, can help with mood, such as reducing anxiety, can improve sleep. And it's been shown that in terms of cognitive health, that moderate intensity physical activity seems to be even more beneficial than low intensity. So, moderate versus low in this case would be aerobic versus stretching, and the combination is even better. And so in this study by Del Pozo, Cruz et al., they saw that an increased daily step count is associated with lower dementia risk. So they looked at 78,000 participants who were 40 and older, and they found that 4,000 steps a day is associated with 25% reduced dementia risk. So I had to calculate this. This comes out to about 2 miles a day. And then even greater, sorry about the wrongly placed comma there. 10,000 steps per day is associated with even greater reduction in dementia risk by 50%. And the protective association was robust across different types of physical activity. And so in this case, whether that was exercise or housework or just being active, and it was independent of genetic risk factors for dementia, which I kind of briefly mentioned earlier. And yeah, another good news is that even moderate increases in physical activity, like regular housework or frequent vigorous exercise, those were all linked to a lower risk of dementia. And additionally, in not just the step count, but the intensity of those daily steps also make a difference. So walking at moderate intensity, and in this case, about 100 steps per minute, and doing those 10,000 steps was associated with the lowest risk of dementia. So this green line here, which we just saw in the previous slide, this is the lowest point of that green line, which is at the 50% reduction line, is associated with 10,000 steps. And then over here, when the line starts to flatten out here, right around 100, that was the point where they saw the lowest risk of dementia, these two factors together. So again, total steps taken in a day and the intensity of those steps matter for dementia risk reduction. How about cognitive activity? So cognitive training can improve cognition on specific tasks, but what we really want to know is whether those benefits can transfer to broader daily activities. One study looked at the effects, these benefits to broader daily activities for up to 10 years. So this study was called ACTIVE, and it did show that cognitive training can have long-lasting benefits that do transfer to everyday activities. So in this study, the participants underwent cognitive training in person, and these were training games in memory, reasoning, or speed of processing. And they did see that everyday tasks, these benefits transferred to those, which included driving and tasks that require sort of dual tasking or that require speed. And now they're looking at whether these benefits reduce the prevalence of dementia 20 years later. Another word I would say about cognitive activity during sort of, in your daily routine is it's more helpful if it's things that you enjoy. So if you hate crossword puzzles, I would not recommend forcing yourself to do it. Whereas if you really love doing them, I think, that'd be a great way to keep up that cognitive activity. Another big topic, which, is a talk in and of itself as well, is diet modification. So there are some sort of popular or most famous diets that are associated with healthy diets. So one is DASH diet, which is limited intake in saturated fats. It's especially good for lowering blood pressures. There's also the Mediterranean diet, and that it consists of higher intake of fruits, vegetables, whole grains, and less meat. And in a study that was shown to be associated with between 11 to 30% reduction in risk of cognitive impairment, dementia, and Alzheimer's disease. And then there's the MIND diet, which is a combo Mediterranean DASH intervention for neurodegenerative delay. And that has the limited intake of high saturated fats and higher intake of berries and green leafy vegetables. And a study showed that there's 17% lower risk of incident dementia on the MIND diet. Okay, social engagement and cognition. So observational studies do support that social isolation is related to cognitive decline. And there are links between loneliness and cognitive decline, which may be related to depression, which is known to impact cognition. Now, it is challenging to study social engagement just in isolation by itself. So there are very few studies where social engagement isn't combined with other factors. So more research needs to be done, but overall, it is highly recommended that people really maintain their social connections for not just their enjoyment, but for the cognitive health. What about sleep and cognition? So poor sleep has been shown to be related to changes in cognition and increased risk for dementia. So altered sleep patterns, where that's poor quality of sleep or really disrupted sleep, are also associated with changes in Alzheimer's disease biomarkers. Now, one thing that's still being sorted out is whether these altered sleep patterns cause changes in Alzheimer's pathology, or whether it's the accumulation of the Alzheimer's disease pathology in the brain that alters sleep. And really it could be a bidirectional relationship after all, but that's still being worked out very intensely by a lot of sleep and cognition researchers. So lifestyle factors and cognition. So multiple factors predict maintenance of cognitive function in the older population. And really, it's the combination of factors that may be more effective than any one factor alone. So cognitive training, physical activity, and modification of vascular risks, all those can have cumulative effects for the best cognitive health. So with that, I'm going to conclude the quick overview of cognitive health. So I guess, yeah, Tony, if there are questions, we could do those.
Yes.
So thank you.
Thank you, Dr. Bang. So now we're going to enter the Q&A portion of today's webinar. Our first question comes from Miriam, and she asks, why did the risk factor for dementia increase over 10,000 steps?
Oh, so it's not that the increase over 10,000 steps. It was actually showing that the reduction was the greatest at 10,000 steps. So in other words, if you go beyond 10,000 steps, that's great, but it doesn't portend much greater risk reduction than 10,000 steps in that study. So you can't do more than 10,000 steps, just to be clear, but it's not that it gives you greater risk. It's just that the most reduction they saw was at 10,000 steps.
Our next question, how can you tell the difference between dementia and perimenopause symptoms?
Yeah, I think that, that's one of the sort of potential causes for, I would say, mild cognitive impairment, but perimenopausal symptoms can include mood changes, cognitive changes. So I think the best way to approach that would be to see the provider for sort of to work up the perimenopausal issues, and if those can be addressed and the person's cognitive health improves, then we would then assume that those changes were due to perimenopausal issues. But if even after addressing those issues, whether it's medication or time passes and the cognition either doesn't change or worsens, then we would assume that it's not really directly due to perimenopausal issues. Yeah.
This question comes from Luis, who asks, how does one get cognitive training?
Yeah, so one way is to do it at home. So, like I was mentioning earlier, if you really like crossword puzzles, you can do that daily. If you love Sudoku, you can do that daily yourself. Other ways to do it at home by yourself would be maybe learning a new language. So there are a lot of language apps out there, and the process of learning a new language can stimulate a lot of brain cells. in a positive way, form new neuronal connections, for example, learning how to play an instrument. Those are also, those can really help stimulate the brain cells as well. But there are more formal ways that people can approach that too. And so one example is to work with a speech therapist. And speech therapist is someone who works with not just speech, but they also work with swallowing skills and cognitive skills. So it's actually three things that a speech therapist does. They're also called speech language pathologists. So, fairly often I would write a referral for what's called cognitive rehab. And that would be to bring to a speech therapist or speech language pathologist. And then they would do an evaluation through cognitive testing. And then they would tailor different types of brain exercises, whether that's games or puzzles, that fits that individual's needs. So that's a more formal way to do it. But yeah, that's those are sort of the common ways to do cognitive training.
Thank you, Dr. Bang, for that insight. The next two questions I'm going to combine because they're very similar. Louise again asks, if you have MCI, should you get an assessment from a doctor? And Christine asks, when to seek medical care and what to look for?
Yeah. So those are very appropriate questions. I do think if people have reasons to doubt that this is just normal aging, and we talked about how that can be hard to tell, if they're forgetting things much more rapidly than other people kind of around their age or around their level of education, something seems to the kind of progression seems more rapid. I think that is a very appropriate time to seek care and evaluation. So I think when there's doubt, objective testing through a cognitive health specialist, it would be very informative.
Ron asked, can low blood pressure cause cognitive problems?
Yeah, that's a good question. Yeah, because your brain basically needs enough blood flowing through it to help it get its nutrition that it needs. So if the blood pressure is too low, that can also be an issue. And there are, many different conditions that can cause someone's blood pressure to drop too low. There are many different examples. But if that's the case, that they're routinely getting not enough blood flowing up to the brain, yes, that would also affect cognition. And so that would be another good reason to get evaluated for why the blood pressure is changing. Sometimes it is, not always, but it's certainly can be a neurological reason as well.
For the infusion intervention for targeting amyloids, hope I'm pronouncing that correctly.
Amyloid, yeah.
Amyloids. For the infusion intervention for targeting amyloids, is that very expensive and is it covered by insurance?
Yeah, so it does it is expensive, but it is as I understand covered for Medicare patients. And some insurances I think will have to it's a case by case kind of a situation. But for most Medicare patients, the coverage is reasonable. Yeah.
The next question is, I read that the medications for AD are harmful to the brain.
Are medications for AD harmful to the brain? Yeah. I'm not sure if there's a specific study, but I'm not aware of medications for Alzheimer's being harmful to the brain. But side effects, there are some side effects of these amyloid removing drugs that can cause issues for the brain. So perhaps that's what you're thinking about. So for example, because these drugs, and I'm talking about the ones called Leqembi or lecanemab and donanemab or kisunla. So those two medications remove the amyloid. They pull the amyloid from the brain, which is harmful. But as you remove those amyloid plaques, that can leave some holes behind because now it's been pulled out. So sometimes that can cause either swelling or bleeding in the brain. And a lot of the times those are only evident by looking at the MRI of the brain. So in other words, even if they're tiny little spots of bleed, the person is not actually affected by those little holes or holes of bleeds or swelling. But in a small number of cases, it's not just evident on imaging, but that can have direct impact on the person, such as, in really bad, like worst case stroke or less severe headaches or confusion. So if people are receiving these therapies, there's a very close monitoring system. It's built into the protocol that people will be getting regular MRIs of the brain. So they're under very close surveillance. And so if there are spots that are seen, even if the person is not symptomatic, there are protocols. The protocol has plans in place for either pausing or stopping, depending on the severity of the situation. So I think I had, yeah, so these are sort of like the tiny little holes on the picture panel B are that's an example of the drug induced bleed. And on the left, these white spots are the evidence of drug-induced swelling. Yeah.
We only have 2 minutes left of time for today's webinar, so we'll try to get through 1 or 2 last questions before we wrap up for today. So our next question is there always a direct progression from MCI to dementia, or does it vary for different individuals? Thanks for this presentation.
I'm sorry, could you just repeat that?
Yes. Is there always a direct progression from MCI to dementia, or does it vary for different individuals? Thanks for this presentation.
Yeah, so it really depends on what the MCI is due to. So if the MCI is due to a reversible cause, whether that's a metabolic or drug-induced, medication-induced conditions, some of those reversible factors we talked about, the MCI wouldn't progress further to the dementia side. Rather, it would actually be reversed and get back to sort of that other circle earlier to normal aging. But if that MCI is really due to an underlying Alzheimer's disease, then we would see that progression of MCI into dementia over time. And how fast that happens is also very different for different individuals. So some people might be sort of in the MCI region for a while, longer than some others. Whereas, so for another person, that progression might be more clear and rapid.
Thank you, Dr. Bang. Ladies and gentlemen, this concludes the Q&A session in today's webinar. On behalf of the Community Health and Wellness team at Suburban Hospital, we sincerely thank you for joining us and extend our deepest gratitude to Dr. Bang for sharing her expertise today. We hope the information provided has been valuable to each of you. As a reminder, please take a few moments to complete the survey that will appear at the end of the webinar. Your feedback is greatly appreciated and helps us improve future programs. Thank you again and have a wonderful rest of your afternoon.